Hello, everyone. Welcome to another Psyccorner webinar. Tonight, I have a very, very distinguished and special guest with us, who'll be joining us for the next 45 minutes. And we'll be asking him questions about his work in psychology and mental health. I have Professor Peter Kinderman, a professor of clinical psychology at the University of Liverpool. He was previously the president of the British Psychological Society, BPS, 2016 and 2017. Welcome, Professor Peter.
Hi there. Hi,
Thank you very, very much for giving us your time. I know you have a very, very busy schedule, and especially with the pandemic, I'm sure your family very, very busy. So really, really appreciate your time to discuss about a very important topic, about your work, the recent book that you published. Fantastic book. Many people I know that have read it. I've gone through it, benefited a lot greatly. So I just want to start off. The webinar is live. Hopefully we'll have questions from the audience. I want to start off really just ask you, you've been in this area for probably over 2 decades, correct me if I'm wrong. What made you, I always ask our guests, what made you get into the field of psychology, studying psychology and then practicing psychology?
Thank you. So, yeah, very good to be with you. It's a simple question, but kind of a difficult answer. So, I grew up, including living with my older brother, who had very serious problems that affected his mental health. And I guess I was really quite frightened of the prospect of psychotic experiences myself. Very worried that I would grow up and experience difficulties myself. Read enough to be frightened of what might happen as I grew older. And I guess I kind of retreated a little bit into science. So I figured that I would be interested in hard science, in physics in particular. I went to university to study natural sciences, but my thought at that time would be that I would want to combine a study of physics with a study of philosophy, interested in things like determinism, whether our path in life is determined by the laws of physics or whether there is free will, and exploring kind of a scientific and rigorous and rule-based explanation for the world, maybe as an escape from the potential chaos of becoming psychologically unwell myself. But I studied a university degree that explicitly wanted us to study multiple branches of science. And so I became interested in psychology. And what I found in psychology and in clinical psychology was really a way of combining those two issues. So studying, using scientific principles to understand our psychology, our mental states, and an exploration what it means to be crazy, what it means to be in charge of your own rationality, what it means to be happy. And so there's a kind of closing of the circle, and I found it very rewarding. I found it very personally fulfilling. And I also think it allowed me to do a bit of campaigning. I was very distressed by the utterly shambolic care that people receive, not only in the UK, but around the world. And it offered me an opportunity to try to do something to improve matters. So it kind of came together.
Excellent. That was really beautiful. Thank you for sharing that with us. You previously, I think the book was published in 2013. Your book, Prescription for Psychiatry, Why We Need a Whole New Approach to Mental Health and Wellbeing. That was released in 2013. And that was, that created a lot of discussions online and offline. Your recent book, I'm not aware if you've published another book, but your recent book published in 2019 that I've really benefited from myself, A Manifesto for Mental Health, Why We Need a Revolution in Mental Health Care, which presents in your book. You argue that we need a radical overview, a new radical approach to mental health care in the UK. Can I just ask a little bit about that? Why you felt that you needed to write the book, and some of the topics that you discussed, you do go into in detail the problems that we have in the mental health care in the UK, and why you think that we do need, in your opinion, a radical change in how we treat mental health.
Sure. I mean, like all authors, I guess I wrote books which portray it as kind of my clever idea, but in truth, these ideas have been promoted by people for decades. So I was lucky enough to have as a supervisor Richard Bentel, who's been arguing along similar lines very eloquently, very intelligently for years. There are many psychiatrists who come from the social psychiatry tradition within psychiatry who've been arguing this way. And as I go into some detail in both books, I think there is a rather wonderful Lithuanian psychiatrist called Danias Puras, who works as a special rapporteur for the United Nations, arguing in a similar vein. So I'm certainly not the only person arguing this. I guess the thesis is that, you know, for many decades now, we've been I suppose there's two things to say. The first is that throughout history, there's been this debate between nature and nurture. Do people develop because of their innate biological character? You know, is it determined that people will behave in a certain way, will have certain problems, and will have certain strengths because it's written into their genes, effectively? Or is it the case that we're shaped more by the things that happen to us in our life? And those traditions have gone on for millennia. In mental health care, the same thing happens, which is, do we become depressed because of the events in our lives and the way that we respond to those events, or do we become depressed because of some malfunctioning of the biological substrates of our brains? And the argument that I and lots of other people have been making is that over the past few decades, the pendulum has swung towards this biological assumption, the assumption that when we're depressed because there's something wrong with our brains, because there's something wrong with our neurochemistry, because we have an illness, because we have a disease. And there are some benefits, I guess, of thinking that way. We tend to be less sympathetic to people who, put it another way. We tend to be more sympathetic towards people whom we believe to be ill. It relieves people of personal responsibility and blame. But I think there are huge downsides to that way of thinking. I mean, in part because although it's a nice idea to think that we would take somebody who is depressed or somebody who is anxious, label them as having an illness, therefore the assumption being it's not their fault. You know, they're not being avoidant of social situations, they're not being rude, they're not being lazy, they have an illness. And therefore we won't be blaming of them. In truth, what we see is that people who do talk about mental health problems, things are changing now, but for many years, people who talk about mental health problems haven't been treated very well at all. And there might be an assumption that it's not their fault that they're depressed, but they've certainly got a disease of the brain. They're certainly people that you wouldn't want your son to marry. They're certainly people who would be bad parents. They're certainly people you wouldn't want as employees. You might be superficially sympathetic to them, but it doesn't create positive outcomes for people. And yes, if you go along to your doctor and you say that you're struggling emotionally and your doctor diagnoses you with an illness, you'll walk away with services. You'll be given a sick note, whether that's a good or bad thing, and it gets you into that sort of system, and you'll be given a prescription for medication, or possibly these days maybe sent off for therapy. So services follow. But as I kind of outlined in the books, I think we could achieve the benefits in a much more humane way, a much more responsive way, being more responsive to people's needs and people's problems. And I'm not suggesting that we shouldn't do that, but I think we can do it without suggesting that the person is diseased, that the fault is some sort of biochemical abnormality that they've been born with, that there's something wrong with them. And instead we should look at the very normal, very ordinary, very commonplace psychological processes that lead us to respond to the events and challenges in our lives. And just to point out that it doesn't necessarily have to be trauma. It could be as simple as struggling with the big existential questions of life. You know, we're born, we have to fulfill our destiny, we have to succeed, and then inevitably we will die. And those questions themselves have, again, throughout millennia, been challenges for us. And instead of seeing the emotional struggles as being born out of a pathology of the brain, I think we can see our emotional struggles being born out of the challenges that we each face just in being alive. So that's what I think we should do. That's how we should approach it, in my view.
I want to come back to some of the points you mentioned just now. You mentioned a word, disease, and we have in the UK and in the West certain different models of approaching whether it's medicine or psychology or mental health care. Would you mind? I mean, there'll be some in the audience who may not be aware of the disease model, for example. What is the disease model? What is the opposite of the disease model, and how is that practically? I know this is a big topic. How is that practically engaged in the real world, if you like?
So one of the things to say here is that it's controversial, and there may well be people listening, especially psychiatrists listening, who are quite angry at the idea that the dominant model of mental health care in the UK is being portrayed by people like me as a disease model. And indeed, quite a few psychiatrists quite angrily point out that we all follow a biopsychosocial model. So biological factors and psychological factors and social factors all combine to affect our mental health. And of course that's true, but lying behind that quite simplistic statement is, what do we think is going on? And it's my contention that the commonplace understanding of mental illness is that these things are indeed illnesses. And if we look at websites, if we look at the information leaflets put on packets of antidepressants and so forth, if we look at the materials produced by a lot of providers in mental health care, they talk about, for instance, depression is a disease like any other. Sometimes people talk about taking antidepressant medication as similar to taking insulin if you suffer from insulin-dependent diabetes. People talk about how we are not stigmatizing people who, for instance, take statins to regulate cholesterol levels, and yet we have this negative attitude towards taking medication for mental health problems. And so the general idea that phenomena like anxiety and depression are best thought of as either illnesses or symptoms of illnesses, and those illnesses are like any other illness. So they reflect an abnormality or a disease process, a pathology of the nervous system. So we think about chemical imbalances. And again, my psychiatric colleagues sometimes get very angry when we talk about chemical imbalances, arguing that this is not the currency of psychiatry. And it may well not be, but I think it is the currency of a lot of information on the internet. It's what people expect. And to be blunt, I think if what happens, and this happens to the vast majority of people who present to GPs, if what happens is you present with distress, your business is failing, you're worried about the behavior of your children, your marriage is failing, you're plagued with self-doubt, you can't motivate yourself. And what happens is that you're basically told that you have an illness called depression. It's a disorder, it's an illness, it's like any other illness, it's a disease, it's a healthcare problem for which the treatment is either medication in the vast majority of cases or therapy, but in both cases to put right something that's wrong. For me, that fits most of the criteria for an illness model, a disease model. So I am depressed because I have a disease called depression. I know I have a disease called depression because the symptoms are feeling depressed and loss of energy and so forth. So the phenomenon is described as an illness. And so that's what I mean as the disease model. We are taught to think, we are even taught in medical school that these things are illnesses. If you read medical textbooks, you will read phrases like, depression can have very serious consequences. Schizophrenia has major consequences for people. So the concept of depression and the concept of schizophrenia is as if they are illnesses that have consequences, not that there are things that have happened in our lives that have made us depressed, or there are reasons why we've started to hear voices. There are reasons why we've started to become paranoid. And if we understand those reasons, we can then move forward and think about ways to help. But when we turn feeling paranoid and hearing voices into a disease called schizophrenia, it becomes an explanation for itself. And I think that's a very misleading way to understand these experiences, because the science of mental health really, in my opinion, doesn't support that sort of model. It honestly doesn't support the idea that we experience distress in our lives because there's something wrong with our brains. It really, the evidence of a lot of decent research suggests that we hear voices, we become paranoid, we become anxious, we become depressed, we harm ourselves, we have problems with eating, we become suspicious of our neighbors, we lose interest in life because of the events that happen to us in our lives, how we interpret those events, and how we have learned to respond to those events. And so it's at the psychological level that I think we should both understand and respond to these problems.
Excellent. Just to kind of touch up on what you said. So I hear what you're saying in terms of, okay, the disease model and how this is very dominant in the UK, in the West at least. If from a practical angle, if a patient were to come to you, or a therapist or psychologist, and mentions certain symptoms, is not able to get up from bed, for example, feeling very low and weak, lethargic, how would you understand that if you don't have a framework to kind of understand, okay, this person is going through X, Y, and Z, and a person needs to be treated with X, Y, and Z. I'm not sure if I'm making sense. How would
So I think we do have frameworks. So one thing to say is that, of course, I and my colleagues who think in the same way understand that a lot of psychological phenomena co-occur. So, for instance, I mentioned earlier about the diagnosis of schizophrenia and about people having paranoid thoughts, unusual ideas, strong, emotionally important beliefs that other people don't share, hearing voices, and they commonly co-occur. So it's more common for people to have both unusual beliefs and to hear voices than for either of those to occur independently. It happens. They happen together more often than you'd expect just by chance. And the same with the experience of depression. So I think it is reasonable to think about a phenomenon called depression, of which low mood, physical tiredness, negative thoughts, pessimism, sometimes negative thoughts about the self, great trouble motivating yourself, all co-occur. And you can see this phenomenon, melancholy or anhedonia or depression, as phenomena that co-occur. So I'm not suggesting that these are individual, discrete experiences that have no relation to each other, because that's not the way the human brain works. So there are times in our lives where a normal and natural, but very, very distressing and probably quite dangerous response to events is to become depressed. And when we're depressed, we have a range of experiences. So we recognize that pattern. But I think recognizing patterns is absolutely not the same as diagnosing illnesses. So for somebody like me to say, I recognize that pattern, that's a pattern that we refer to as depression. That's different, at least in my mind, from saying you have an illness called major depressive disorder. People get depressed. The same with anxiety. So when you're anxious, you fear that something bad is going to happen. You're attentive to threat. Your heart rate goes up. You start sweating. You feel the surge of adrenaline. So we know that various different experiences are related to the phenomenon of anxiety. But I wouldn't characterize anxiety as a disorder. I would characterize anxiety as a particular understandable psychological state. So then what do I do about it? Well, if you came to me and you explained to me that you were depressed, I would try to understand why you're depressed. I would ask you questions about your lifestyle, about things that you might be doing which we could discuss. Yes, I would genuinely regard myself as an expert in psychology, but you're an expert in your life, and we would discuss what you're doing. So for instance, you might talk about your ambitions for the future and whether they're likely to be fulfilled or not. When I was a teenager, I had 7 ambitions for my life, and I've achieved 3 of them. Well,
I mean,
you know,
that's a good achievement.
well, you see, the glass is half full, right? So,
yeah.
so we could talk about whether I'm depressed because I'm not achieving things. We could talk about, you know, my ambitions for the future. We could talk about, you might be having financial difficulties. You might be having relationship difficulties. You might be having a crisis of faith. You might be having, you might feel that you haven't achieved the things that your parents wanted for you. You might feel that you've let down your children. There are huge numbers of reasons why we as people might become depressed. And when we become depressed, we have negative thoughts, we feel pessimistic, we feel tired, we can't motivate ourselves, nothing that we do seems to enjoy ourselves. There's also lifestyle issues. You know, if you're not doing the things that would give you a sense of meaning and purpose in life, then it's going to be difficult for you to escape from a trap of depression. So we can do all of those things. We can offer psychological help, practical help. And, you know, if you were to go to your GP and they were to offer you antidepressants, the antidepressants are likely to have an effect on your mood. So we can talk about all of these things without assuming that what you're talking about is an illness that needs to be treated. This is an event in your life that we need to address. You need to address it yourself if you can, but there's no shame in seeking professional help. But just as, you know, if you're, I'm sitting looking around my front room here. So, you know, if my house started to develop a problem with damp, I'd call in a professional and they'd see why the problem is happening and we'd sort it out. And, you know, it might take some effort and it might take some money, but we address the problem. And it's similarly, if your life isn't going in the direction that you had planned for it, yeah, we'll talk about that. I can't give you advice about your life, but what I can do is talk about psychological science that tells us something about how these experiences work. And some of it is really simple. So there's stuff about the way that we think, the way that we deal with conflicts between our goals. So let's say that you want to be financially successful, but you also want to lead a moral life. So maybe there's a conflict. Do you take a business opportunity that isn't quite as ethically appropriate as you would want? How do you deal with that conflict? Maybe you have a path in life that means that you deviate from your parents' wishes for you. That's going to be a conflict. Maybe you and your wife have or husband have, you know, different plans for things, and how do we deal with conflict? When we get into patterns of negative thinking, the way that we think can change the way that we seek out evidence, and we tend to get into loops of confirmation bias. There's also practical things. So when we become depressed, we often stop doing things that are rewarding, meaningful, and purposeful for us because we're depressed. And that means that we're likely to become more depressed because we're not doing the things that are rewarding. Now, all of that is relatively simple. It just helps to talk it through with somebody who's taking a professional perspective on these things. So we can help. But of course, in my view, none of that suggests that you're suffering from a disease called depression that needs to be treated. There's a crisis in your life that needs to be resolved, and that's a very different thing.
I mean, everything you said really resonates with me, at least, and hopefully the viewers who are watching now and will be watching later. I want to also ask you about, well, you talked about the disease model, talked about, you know, in your previous work, you talked a lot about psychiatry and how that can be problematic. And I know you mentioned, you know, a lot of, not everyone in psychiatry, you know, I have friends who are psychiatrists. They're very, you know, they have empathy and they understand this psychosocial kind of model. But there are some that I've come across, and I'm sure you've also come across that, you know, the very, you know, they will, everything what you said they will say, you know, put in the bin, put in the dustbin, right? And I want to ask you about the diagnosis tool, for example, DSM, for example. We had previously in our Psyccorner, Professor Francis, Alan Francis, who was the chair of the DSM-4. And although he's not, people like him, he's not anti-psychiatry, but he's very critical about the industry, if you like. So I want to get your views on the DSM and how, obviously this is a huge topic. I mean, most, if not all clinicians, psychiatrists, you know, and mental health practitioners, they have to refer to in their training and post-training, their DSM. And there are others, I've read a lot of literature, I've spoken to a lot of people who are not anti-DSM, but they have a lot of concerns about the actual, the tool that they are asked to use. So let's get your brief thoughts on that.
So I find it all extremely frustrating. And, colleagues of mine, especially Anne Cook, who I think writes very eloquently about these things, thinks about it as, a craftsperson who has nails and hammers in their toolbox and nothing else. The idea that, if all you have is a hammer, then everything looks like a nail. So, for instance, I'm frustrated. It seems to me that these very caring, well, most of them, some of them you wonder why they did go into psychiatry, to be perfectly honest, especially if you look on Twitter. Some of them, dear God, are there patients watching? Anyway, most of them are very intelligent, very, very well trained. Medical school is great, right? And really very intelligent, caring people. And yet, they reach into their toolbox and they pull out a hammer and they start whacking things and assume that they're nails. So, for instance, it is worrying how we all use internet-based tools these days. How much screen time people have, especially adolescents, social media use, internet gaming, and there are all sorts of reasons why it's both good and also reasons why it's worrying in terms of the amount of time that people spend, their quite restricted focus sometimes. And, I can see why excessive screen time might be really quite worrying for parents when they observe it in their children. And we should have a conversation about that. We should think about whether there are good guidelines for teachers and youth workers and parents, and whether there's advice that can be given to children and young people themselves about screens and gaming and so forth. And clearly, for some people, it becomes a problem. Some people spend vast amounts of money on the internet. Yeah, so you got the point, right? It's an open question as to whether it's a problem or not. Diagnosing internet gaming disorder and then setting up a clinic to treat it, really? Why don't we address the issue, which is, what is the harm, or what are the harms of screen-based activity in young people, and what would be good guidelines? What do we do when kids are using screens too much, and how can we spot it? Not, can we diagnose the kid with internet gaming disorder and then treat it? We've in the UK just returned to school this week, right? So kids from the age of 5 up to 18 are returning to school after more or less a year distance. So for young kids, getting re-engaged in the social activity of school might be quite daunting. They might be quite nervous about it. We need to address that. But diagnosing kids with social anxiety disorder and then treating it is just whacking the non-existent nails with stupid hammers, in my opinion. So the reason why I get frustrated at DSM is because the diagnostic model, I think, is a frustratingly stupid way for intelligent and caring people to respond to the needs of their patients. Why are you feeling as you feel? What's going on in your life? What's happened to you in your life to lead you to be so paranoid about your neighbors? A bearded, brown-skinned man. Why on earth might you be paranoid walking the streets of Britain? Well, let's think about it just a little bit, rather than, do you have schizophrenia or not? It just strikes me as such a leaden approach to people's problems. And including going back to depression, do you or do you not have major depressive disorder? If you do have major depressive disorder, then we'll treat it. If you don't, then lucky you, there's nothing wrong with you. It's such a lumpen and inflexible way to deal with the complexities of human problems. The other thing that's frustrating about it is that embedded within these systems, both the DSM system and the World Health Organization's more European system, ICD, is the possibility of doing things differently. So what happens when you diagnose somebody with major depressive disorder is you ask them what their experiences are, and they tell you. So if they were to meet the criteria for major depressive disorder, they would say, for more than 2 weeks now, I've been feeling very low. most days. I've lost pleasure in the things that used to give me pleasure. I have negative thoughts about the future. I'm not eating properly. I'm not sleeping properly. And to be honest, I've started having suicidal thoughts. And instead of saying, wow, that's really quite worrying, okay, let's get to grips with that, they go, okay, shove that to one side, we'll just call it major depressive disorder. And you think, what's happened to all of that information? Yeah, that information is there, right? We can record it, we can store it. So we could write to each other, and I could say, dear Dr. Jones, please see this pleasant young man who reports that for the past 2 weeks he has been experiencing the following things. And Professor Jones will go, wow, okay, well, that sounds very serious, but it's very, very understandable. Here you go. So I'll give you a little story. So my point is that in the DSM system, the diagnostic framework, the idea of do you or do you not have a mental illness means that information is lost. We lose the complexity of people's lives. We lose the detail of people's lives. And it frustrates me because the detail of people's lives, instead of being understood in that sense, are turned into symptoms, ticked off, and then we respond to the diagnosis. And it's leaden, it's stupid, it's frustrating. So one of the things that I do is I teach master students, and part of the assessment that I give them is to give them a little vignette of a case, and then ask them to do the sort of formulation that a clinical psychologist would do. And so I've done this for about 4 years now. And of course, they sort of write to please me. And so they write a cognitive behavioral formulation. Of course they do. Here is the young man. Yeah, he's clearly very depressed. It's clearly a problem. So depression, treatment of choice is CBT. So we'll do CBT. And I must have kind of set this task for about 50 students now. And in the little vignette, what I say is, here's the guy. And so I write it in the form of a GP letter, and it says, please see this man as a clinical psychologist. He reports that for a few months now, his business has been suffering financial difficulties. And he's become very worried about not only his business, but about his financial position. He reports that this has put a strain on his relationship such that he's now having arguments and rows with his wife. And then I list the symptoms of depression. Not one student over the past 4 years has said, let's give him a small business advisor. Let's get the Chamber of Commerce involved. Maybe he needs a lawyer. Maybe he needs some advice. Maybe he needs a loan. Maybe he needs some support for government for his business, because it says directly in the vignette that I give them, he reports that his business is having financial difficulties and this has led to, and nobody addresses the cause. Wow. They treat the illness, non-existent illness in my opinion, not non-existent, the problems are real. Referring to it as an illness takes you away. So instead of helping the guy address his relationship, plan for the future, yes, of course, address his psychological issues, but also address the root cause of his difficulties, shuffle to one side, treat it. Because I'm a psychologist, they don't suggest treating him with Prozac, they suggest treating him with CBT, but the principle's still the same. So the reason why I get frustrated is that it's a leaden and, in my opinion, a stupefying approach to people's problems. We lose information, we lose subtlety, we lose data. The person's personal story is lost, and we end up treating the illness and not helping the person. And I think, Alan Francis is a great guy. I've met him. I mean, he's a nice bloke. He's clearly very intelligent. He's very caring. I think some of his insights about the problems that are ensuing from DSM-4 turning to DSM-5 are very astute. In my opinion, though, the problems with DSM-4 were there inherent in the nature of the problem. And instead of inventing new disorders, which DSM-4 did under his tutelage, Alan talks about trying to stem the tide of increasing medicalization of mental health problems. But in all honesty, he was part of the problem, not part of the solution. So he's a nice bloke, but he's caught in his own system of hitting everything with a hammer, I think. Sorry, he's going to be angry at that, but.
Thank you for that. I mean, I love your passion. When you talk, I love it. I just love your passion. For the actual the science, if you like, the field that you're working in. I love that. Whenever I see people who are very passionate about it, I can see that you care about what you do and you care about the work that you do, and that's really, really, that's what we need more of. So thank you, really, really appreciate that. I want to ask you two further questions, and I want to try and ask them without really offending certain professions, if you like, right? To what extent, in your opinion, do you think, like, we have a we have the NHS, and NHS, I think, in my opinion, and I'm sure everyone would agree, is it's a national treasure. It's something that I think it's the envy of the world. I would say it's something that literally saves lives, and it was introduced after the Second World War, where the economy was really, really down, and the good thing about that, the government at that time, they saw the vision, they had the leadership, the courage, the bravery to support the vulnerable people, support the people of the UK. But obviously, over the decades, the NHS still is the envy of the world, still is a great institution. I don't think, I think we as citizens of this country, I would say we need to fight for it, not get it privatized and whatnot. But to what extent, in terms of mental illness or mental health care, and what you've mentioned, has economics played into how we perceive mental illness or mental health care? I mean, I've had students who are GPs, and they say, look, we only have probably 5, maximum 10 minutes with the patient, and the patient come and they will explain their concerns and the worries and the problems that they have, and we're not trained. Number one, not trained in therapy. Number two, 10 minutes you can do so much. So what the best that we can do, and this is a GP, that we can only prescribe them something, right? So I guess my question is, has the disease model that you talked about become more dominant because there's money behind this, finance behind it in the psychiatry world? If that makes sense.
Yeah, and it's happening for clinical psychology as well. So my profession is being reasonably well funded these days, because people want a psychological alternative that's within the NHS structure. So you go to your GP, you talk about your mental health problems, and your GP will refer you to a psychologist or a therapist. And that, I think that's better than taking medication. So I think that one of the things that's happened in the UK, because the National Health Service has been so important to people from all sides of the political spectrum, that although psychiatry and mental health care has taken a disproportionately small part of the budget, at least it's protected. So my argument would be that, rather unfortunately, I'm hesitating because this is a very political point, right? Which is, what we need to do is to it's a social response. So we live in a country which, or at least I live in a country which doesn't seem to value children very much. Remember the scandal a few years ago about these mosquito devices? So you could put up an ultrasound generator to scare children away from your property. Yeah, great. We don't like taking our children to restaurants. They're irritating. There are children-free hotels. We don't like children very much. And then we pack them off to school and we test the poor little buggers to death. So they have to perform. They have to learn. So instead of having well-funded, state-funded childcare, where the kids will play and learn to interact with each other, learn about morality, learn about personality, learn about sharing, learn about communities, what we do is we pack them off to school and give them SATs test at the age of 6. And so our education system is perfectly attuned to make kids anxious and have problems with attention and discipline, which then get diagnosed as ADHD and given Ritalin, and I think that's wrong. We segregate and teach. We live in a racist society. We live in a homophobic society. I mean, we saw the Oprah interview is, this stuff is going on. We live in a very unequal society. So, Dido Harding and Jacob Rees-Mogg and donors to the Tory party can walk away with taxpayers' money, and, ordinary working people end up paying more. We live in a very undemocratic society where, the world was created for people nearly like me, right? So our society was created for heterosexual white men, but from the upper echelons of society. We live in a very undemocratic society. We live in a society where homeless people sleep on the streets. And you look at other societies and you see better employment protection. You see better health and safety, because getting your fingers caught in pressing machines at work is not really very good, right? It's not a health and safety nonsense. It's actually protecting working people against getting injured. We see in other societies unemployment benefits being 80% of your previous income. We see, for instance, in Finland, where homeless people are given accommodation and a basic income, and 4 out of 5 of them don't use services in the future. They rebuild their lives and move on. So it's the focus should be on social services other than medical ones. I'm not even really arguing that. So I'm not particularly arguing that we should double the number of psychiatrists. So in part, I think we should probably focus more on primary mental health care rather than secondary mental health care. But where the investment needs to come is not in more clinical psychologists, but in more social services, better unemployment benefit, a progressive taxation system, universal basic income. That's where the remedies lie. And I think that the idea that people who have failed to thrive in a late capitalist society have something wrong with them that should be adequately treated by doctors in privacy using medication is just a sign of the problem, not a healthy solution.
I mean, you mentioned about universal basic income. I'm really for that. I think this is something be really beneficial for the world, really, the UK in particular.
And I mean, there have been some trials of it, and sometimes there are twists to it, and there are ways of guarding it. But I think that could be extremely important. And what you notice with these sorts of social interventions is, I think one of the Conservative candidates for the mayor of London was saying that he didn't, it might have been the minimum wage, or it might have been a universal basic income, but he didn't want money being given to poor people because they'd spend it all on drugs. And you just, it's a depressing experience. But of course, I mean, what a universal basic income would do is it would liberate people from need. What that people would then do is they would choose to work hard because they get rewarded for working hard, but they wouldn't need to do things that they didn't want to do or weren't able to do because they could fall back on a safety net. Universal basic income, but like I say, other things, reform of the education system. I mean, some things admittedly are more difficult. So, it might be quite difficult to eliminate racism and homophobia from our society. What we could do is reform the education system. I mean, that's within the gift of politicians. And then I think other things would follow. I mean, there's other things too. Male violence, obviously the abuse of children. There's quite a lot that we should be doing on a societal level. And I guess what that means is, and maybe my opinions are softening a little over time, which is, the solution isn't to beat psychiatrists over the head with sticks and make them become psychological therapists. Maybe just let that rest where it is. As in, the healthcare system doing what it does. What we need to do is think, right, we're coming out of the coronavirus pandemic. We've got Brexit breathing down our throats and going to cause mayhem economically. What sort of a society do we want to build? And in my opinion, we shouldn't have a vulture capitalist Jacob Rees-Mogg society and then let the psychiatrists give antidepressants to the people who fall through the net. We need to build the sort of society that we tried to build in 1946. chances are with this government in charge, well, good luck to you.
And also, I mean, just to go for a tangent, I mean, there's been a number of studies by economists, and that trickle-down economics really doesn't work. But if you help the poor, the people on the bottom of the ladder, and you support them, and they will actually support the society, support the community that they're in.
Yeah, you know. But BC, I don't think this is a tangent. I think that if you come at these sorts of issues, you know, our well-being as a nation and our well-being as individuals, if you come at that from the perspective of what, you know, do you have a mental illness and what's the treatment for it, or even what's the etiology of depression, then it looks like it's a tangent. If you ask questions like, what gives us a sense of meaning and purpose in life? How can a man or a woman be fulfilled in their life? What gives us a sense of safety, of satisfaction, of optimism, of community spirit, of love for your neighbors? Well, it's not taking an adequate dose of sertraline. It's feeling that you're living in a society that will reward you for the efforts that you put in. Tolerance is the wrong word, but, you know, embracing the benefits of living in a pluralistic society. Those are the things that make us feel good about ourselves. So I don't think it is a tangent to talk about things, for instance, things like social and economic inequality in a discussion about mental health. I think it's absolutely central to mental health to talk about those things. I think it's actually a tangent to talk about serotonin. Social equity is what we should be focused on. Serotonin is probably an irrelevance.
Thank you for that. Two more questions, if you don't mind. I'm going to ask you a direct question. A lot of everything you've said really resonates with me, definitely, 100%. And I love the passion and the energy that when you speak, I just love that. Are you against treating a patient of mental illness or even suffering from acute mental illness, totally against treating them with some sort of psychiatric drugs?
No. No. So if this evening I were to have some sort of a breakdown and become psychotic, I would want somebody to offer me drugs. And, you know, the medication that we offer, the drugs that people take, well, I mean, I think the outcome data in the long term is really poor, right? So the outcome data for antidepressants is not nearly as good as people claim that it is. And some of the adverse effects are really worrying. So, for instance, antidepressants seem to be quite commonly associated with increases in suicidal thoughts. And the, you know, outcome data for antidepressant medication beyond about 8 weeks seems really very vague indeed. They don't seem to be stunningly effective drugs, but they do things to our serotonin system. They do affect our neurotransmitter levels. And I have friends who not only said that antidepressant medication has been very helpful for them, but some of my closest friends are taking antidepressants long term. I'm much more focused on what we think the drugs are doing. So I, for instance, do occasionally drink alcohol, and it's a drug. It affects me. It's not good for me physically, and because it's a depressant, it's, you know, it's probably not a fantastic drug, right? It's not very safe. It's not very healthy, and the social consequences of alcohol are immense. But, you know, if I've had a stressful day, a glass of wine will be immorally, but definitely pleasant and effective. It's not treating an illness. It's a drug that has an effect on me. If I was acutely distressed, psychotic, paranoid, angry, possibly a danger to myself or to others, then antipsychotic medication, neuroleptics, may well be helpful. But they're not treating schizophrenia. They're powerfully sedating drugs that both sedate but also offer a weird buffer against stress. So things that were important to you become less important when you take antipsychotic medication, and that may well be helpful. So if I became manic or paranoid, if I were to take a drug like risperidone, then I would probably calm down, and that may well be helpful. So my view would be that these drugs, it's what Joanna Moncrief points out, which is the drugs are drugs. They're not treatments, they're drugs. So drugs have effects. So if what would be useful for you would be something that would reduce your levels of stress, buffer your levels of anxiety, be calming and sedating. If it was a medication that would help you sleep, good, great. So I would like psychiatrists to be highly trained medical professionals, responsive to the needs of their patients and aware of the power and potential beneficial effectiveness of the drugs that they prescribe. But that's not the same as treating illness. So I do think drugs have a place, but I vote with Joanna Moncrief that these are drugs that may have beneficial effects for people, but not that they treat underlying illnesses. So I would vote for short-term, symptomatic, adjunctive use of medication.
On a temporary basis, not a long-term solution to treat.
Well, probably. I mean, I would hesitate slightly. So, okay. For my colleagues, or not my colleagues, for my friends who do tell me that the medication that they take is necessary for them, scientifically, I have some doubts, because so when you smoke cigarettes, nicotine is a very powerful drug, so it makes you relaxed and alert. It's a great drug, but I wouldn't smoke and I wouldn't vape nicotine, because one of the consequences is very, very soon after you vape nicotine, very soon after you inhale nicotine, although immediately it makes you both alert and relaxed, which is a great feeling. After about 2 or 3 weeks of using cigarettes or vapes, your body adjusts so that what happens is that when you vape nicotine, you feel alert and relaxed. And when you stop vaping nicotine, you feel tense and nervous and distractible. So what then the vape of nicotine does is it returns you to a vaguely normal state. And there is quite a lot of evidence that that's true also for antipsychotics and for antidepressants, that what happens is they induce a change in brain chemistry, which is temporarily perhaps beneficial, but the body adjusts, the homeostatic mechanisms kick in and you readjust. So for instance, if you take a SSRI, a selective serotonin reuptake inhibitor, and your brain has more available serotonin, you downregulate the sensitivity of serotonin receptors in the brain. When you stop taking the antidepressant, because your brain has adjusted to the presence of the antidepressant, and your brain has adjusted to the relative increased availability of serotonin, you then get a rebound effect when you stop taking the antidepressant. What happens is your brain is then able to reabsorb more of the serotonin because the drug is no longer there. You remove the serotonin from the interstitial spaces between your nerves, and you get effectively a depressive effect. And the same with antipsychotics. So people get rebound psychosis. So you stop taking the antipsychotic, your dopamine receptors are no longer blockaded, and you get a dopaminergic surge. Well, yes, that's what you get. So the reason, I'm scientifically suspicious as to whether people's report that the antidepressants are necessary long-term may well be an artifact of the fact that their brains have adjusted to the fact that they're taking the drugs, rather than their brains need the drugs in order to keep them happy, if that makes sense. So I'm suspicious of that. But, if that's what floats their boat, sorry, that's a bit glib. If that's what they need, that's fine. I still don't think they have an underlying illness that's being treated with this drug. I think what's happening is that the drugs are boosting or reducing the availability of serotonin, or reducing or changing the sensitivity of neuroreceptors, and that has the effect that it has. But I don't equate that to the successful treatment of an illness. I think that's about possibly misguided continuous use of brain-altering chemicals, and I'm not sure that that's a wise long-term strategy, to be honest.
And there have been studies in the UK and America and other parts about withdrawal symptoms with people who've been taking antipsychotic drugs.
And of course, for both antipsychotics and antidepressants, the withdrawal symptoms look a lot like the so-called illnesses, the supposed illnesses.
Yeah.
So if you stop taking if you were to take an antidepressant for a long period of time and then stop taking it, you're likely to become depressed because of the effect on your serotonin system. If you take an antipsychotic for a long period of time and then stop taking it, there's going to be a rebound effect on your dopaminergic system. It's going to be a little bit similar to taking a drug that stimulates the dopamine system, and you will probably get quite paranoid or have weird hallucinatory experiences. So the adverse effects are quite significant, but they also have the power to mimic what is misinterpreted as the underlying illness, and that's, you know, that's a catch-22.
We don't have much time. I want to go back to discuss about NHS. So is there do you think, like, I mean, some of the work that you're doing and your colleagues and similar people are doing in the area of psychology and talking about, you know, we have to take a more broad, more holistic approach to mental health care, not just from the medical biological perspective. Could there be a danger, particularly in the UK? Okay, the way, unfortunately, the NHS is going and the different protocol systems that we have in the UK, do you think there'll be a danger where, okay, certain bodies or government might say, okay, then we don't need the NHS. We just, okay, people are just need to get on with their life. You know, if it's you know, about the social interactions and relational issues that's causing the problems, is there a danger of you know, if we press on that and that this becomes more dominant in our discourse and language, the danger of, okay, this will be completely parked on the side and people will not get the treatment or get the support that they really need?
Well, I think we've seen with Brexit that there is a real risk that malign politicians with evil intent will misrepresent things to their own political advantage. Yeah, this is what you voted for. Well, actually, that's not what we voted for, because you said that we wouldn't leave the single market. So you can't claim, no, 52% voted for it. It's clear and settled will of the British people. But hang on, you said that there would be no border down the Irish Sea. No, the British people voted. Well, they didn't, right? So it is always possible that politicians will misrepresent the situation to their own end. So yeah, I will give you the very real possibility that me arguing that we should invest in social care because our psychological well-being depends on social and psychological factors more than biomedical pathologies, could be misused by evil lying right-wing politicians to defund the NHS and leave people homeless. Yes, but the fault there lies in the evil scheming right-wing politicians, and the problem is that some people are stupid enough to vote for them, not that actually we should pretend that being depressed is actually an illness, because if we pretend that it's an illness, it might just protect you against right-wing politicians. I mean, I have to say, I'm not sure that an illness model in psychiatry really protects us against Jacob Rees-Mogg wanting to go through our pockets. I mean, it really doesn't. I mean, since when have you seen Jacob Rees-Mogg, Marc Francois, and Boris Johnson saying, oh, well, you know, because our well-being is dependent on psychological and social factors, we'll introduce a basic universal basic income and increase the minimum wage, increase employment protection for people, and have a massive anti-racism campaign. Oh, we're going to abolish SATs tests in schools. No, of course not. I mean, the biological model of mental illness simply doesn't lead to the Tory party deciding to do all of those good things. What it might do is mean that there's a little bit of trickle-down funding for biomedical psychiatry in the NHS. And yeah, you know, I'd like to keep that, please, because I don't want the NHS to be defunded. I mean, I'm in a little bit of a difficult position here, because yeah, I really don't want to give ammunition to people who would misuse it. But I don't think that I've said anything like that ever. I do think that our benefit system should be based on people's needs and not on putative illnesses. But I think it would be an act of Jacob Rees-Mogg style dissimulation of the truth to say Peter Kinderman is arguing that people shouldn't get benefits if they're ill. I'm not saying that. I'm saying the benefit system should be massively increased, be more equitable, and be based on people's needs, not on putative diagnoses. But I'm not saying strip people of their benefits. I'm just not saying that. So yeah, I guess there's a risk that people would misinterpret what I'm saying. I think that some of my psychiatric colleagues are willfully and deliberately misinterpreting what I'm saying. Oh, Peter and Lucy Johnson and Anne Cook say that there are no such things as mental illnesses. Well, no, what we say is that the illness model is probably not the most scientifically valid way to talk about people's difficulties. We're definitely saying people's difficulties are real. It's a misrepresentation of the facts. So yes, people could misrepresent me, but that's their problem. Am I putting things across that are more capable of misrepresentation? No, I don't think so. I don't think our mental health care is so utterly brilliant that it shouldn't be reformed. I think it's pretty bloody miserable, actually. A few years ago, my mother was dying of cancer. So I was visiting her regularly in hospital where she was receiving chemotherapy, and eventually she died. It was a very ordinary NHS hospital.
I'm sorry to hear that.
These things happen, but it was just an ordinary NHS hospital. At the same time, I was visiting clients in NHS psychiatric hospitals. We'd go through an airlock system with grumpy security guards going, "Who are you?" And then you'd go into the first bit of the airlock, and then they lock the door behind you, and you go to the next one, and you go into these ward environments, which chaos, and ignored by the members of staff. Patients going, "Are you a doctor?" And I say, "I'm sorry, I just chaos." And if the argument is by arguing for a psychosocial perspective on mental health, you might threaten the wonderful psychiatric system that we've got now, it ain't that wonderful. So anyway,
I mean, yeah,
I could see the risk, but
thank you. What I've heard from you and understood, I mean, it's really very balanced approach. I don't think what you said is radical in the sense that many people will not agree with you. I think a lot of people out there who are watching, and both experts and non-experts, they would agree with you 100%.
There's one thing I want to say, which is
sure.
I don't think what I'm saying is radical for another reason, which is this isn't anti-psychiatry. There are very large numbers of psychiatrists who want their profession to be more focused on the experiences of people, their lives, responding to the things that have happened to them, using their skills as medics to respond to the real, understandable, ordinary crises of human lives. They're just using their skills as medics to do that. And that's what I'm reflecting. So this isn't a guild dispute between people who think like me and psychiatry. This is the social psychiatry tradition within psychiatry. And it's always been there, and it's very powerful. I just think that over recent years, it's been overshadowed by a much more bureaucratic, rapid turnaround, diagnostic, treatment-based approach. And I think we should return to more of the traditional of social psychiatry from within that profession.
Yeah. Do you think that you've been discussing this, you've been academic as well as a clinician for nearly over 2 decades in the UK. Do you think that your message is getting, people are hearing you, listening to you, whether it be other clinicians or in the general public, if you like? And do you see a change, even a little bit? Do you see a change?
Yeah. So I teach young people, and I've got children, and I think young people are much more open about mental health, and that's good. They're much more willing to come forward. I think we have to deal with the fact that if 30 to 40% of university students are talking about, in quotes, having a mental health problem, I think we need to have some discussion about what that means. But I think it's great. I think people are open. I think the royal family the 2 royal princes have talked about it. Football stars have talked about it. Rappers have talked about it. Musicians and so forth. So I think we're talking about mental health, and that's great. I think people are leaving behind the stigma. It's an everyday topic of conversation. We've had massive investment from the government over many years now into psychological therapies, and I think that's good. We've got quite a lot of discussion about these sorts of issues. So you hear on the radio, you see on TV, people talking about, what the nature of mental health problems is in the way that we've been talking about it this evening, and that's great. In Norway, they've now introduced a law that says that all psychiatric hospitals have to reserve a certain number of beds in their wards for people who want help but will refuse medication. So you don't have to buy into the medication model to go into hospital, which I think is a really positive move. We're seeing reforms of the Mental Health Act that are moving in the right direction. As I said, the report from the Special Rapporteur to the United Nations, Denise Puras, I think was very positive. We've seen senior politicians like Norman Lamb and even David Cameron talking in much more positive, in my view, more psychosocial perspectives on mental health. So yeah, I do see change. It's perishingly slow. So, if I were to be stupid enough to set a benchmark for success, I'm absolutely bound to die before we reach it. But we're kind of moving in the right direction, slowly.
I think, like people like you, the work that you're doing, I think is contributing greatly in that. Final question. I think you mentioned Norway. Is there a model, whether in Europe, outside Europe, that you think, okay, we in this country, the NHS, we hope to reach in 10 years time or 20 years time? Is there a model out there that you think, okay, it is not maybe perfect, but it is better than what we have at the moment in the UK?
No, I think the UK is not as bad as many places. It differs from place to place and from profession to profession. So there are good things about the practices in Norway. There are good things about practices in Finland. There are good things about practices in France and Italy and the Netherlands. America has some difficulties. Britain isn't too bad. I mean, mental health care around the world has been utterly shocking, and in some of the Southern Hemisphere countries, even quite large and reasonably well developed countries, mental health care has been really, really bad. Britain isn't too bad, although we've got a long way to go. I think it's much worse in other countries. No, I think what we have to do is pick the best from different countries and take examples of good practice from one nation and translate it to another. I mean, I suppose I should just say that myself and Pat Bracken, who is a leading psychiatrist from the social psychiatry side of the profession, is the first author on a very influential paper in 2012 about promoting a social psychiatry perspective, and various colleagues. We're directors of a charity where we intend to build our own psychiatric unit effectively in a large field outside of Dublin. So we spent €2 million on some farmland, and we're going to build a hospital there. So we're going to put our efforts where our mouths are. So we hope to report the best, you see. So.
That's incredible. That's amazing. And I hope and pray that you get there and achieve that very soon.
Well, but one of the interesting things is that, I mean, it's not my money, right? I'm not that wealthy. But large corporate donors in the Republic of Ireland are interested in investing in mental health care as a charitable organisation. And I think that's a sign of the times, that I think people being proud to sell their land for a psychiatric unit, proud to have residents with serious mental health problems as neighbours, proud to donate money, wealthy individuals, but proud to donate money to psychiatry is a sign that maybe we're turning a corner to this being something where, this is what civilized nations do for the more vulnerable members of their community, rather than something to be shut away in the asylum behind the big walls.
Yeah. Thank you really. I mean, I can't express my gratitude enough. I think we could go all night, and I could listen to you all night, all day. Honestly, I can just listen to you. Everything you mentioned, it just resonates, and it's for me, it's been therapeutic listening to you. And I've been following you on Twitter, and following your work. And I've learned so much from your books and writing that I really encourage our viewers, listeners, please follow Professor Peter Kinderman on Twitter. I'm not sure if you have a website yourself, Professor Peter.
I not really. I'm not. Most of it is via Twitter.
Yeah, so please go on Twitter, search for Peter Kinderman. There's amazing discussions that he engages in with other colleagues, and you learn a lot. I've learned a lot. I'm sure the viewers have learned a lot, and it'll be amazing for us to bring you on again to continue the discussion, hopefully. And then I apologize. We wanted to have this discussion back in November or December, I believe, but illness and the COVID-19 pandemic really messed everything up. So really appreciate you giving your time, and really appreciate you taking time from your family. God bless you and keep you safe, keep you healthy. That passion and that love and the energy. I hope to that the more people like you do the work that you're doing, and I'm really, really happy that I've actually had you on the Psyccorner, and I can't thank you enough. So really thank you for that, and hopefully I'll see you on another Psyccorner again.
Thank you very much. You're too sweet. Thank you.
Thank you. Viewers, listeners, thank you for watching another Psyccorner. Hopefully we'll do another one with the great professor again very soon, and with other guests. So please join us again soon.